present you a very particular case of two complications in one patient. A patient 70 years old, male with cataract and epiretinal membrane. Vision was 5/10 in the right eye. You can see the membrane. And I performed surgery, phaco-IOL vitrectomy, peeling and air. On the first day, the IOL is in the bag and the retina is attached. You can see the bubble of air 1 day post-op. This is the OCT 1 day post-op. It looks beautiful. 1 week later, again, the IOL is in the bag, the retina is attached. You can see the OCT. 2 weeks post-op, it looks very bad with one haptic of the IOL in the sulcus, tyndal, logosis, the retina is attached, but what happened? So I have reviewed of the video of the surgery trying to understand. So you can see the rhexis. It is actually very large compared to the usual rhexis I do in combined procedures. The IOL tends to luxate in the anterior chamber, and I have to use injection of BSS and especially injections of viscoelastic to keep the IOL in place in the bag. This is the injection of viscoelastic to push back the IOL in the bag. I don't pay too much attention to these steps and I move forward with the peeling of the epiretinal membrane that you will see through the view of the intraoperative OCT that confirms step by step the regularity of the peeling and the completeness of the maneuvers. You see the membrane is lifted up and removed. The retina has no consequences besides the disappearance of the epiretinal membrane. And surgery is finally completed with fluid air exchange, injecting air in the posterior chamber, in the vitreous chamber. You will see that even during this maneuver, the pushing effect of the air tends to luxate the IOL in the anterior. So now I know what happened. One haptic of the IOL was luxated in the anterior chamber 10 days after surgery due to the air in the vitreous chamber and the large rhexis. And then iris irritation due to pigment dispersion, bleeding in the anterior chamber, and increase in the IOP, which is UGH syndrome, uveitis, glaucoma, IFEMA syndrome, due to the IOL. So then what happened? The patient had the IOL in the bag, but the IOP was very high. This was the OCT 1 month later. I don't want to reopen and do traumatic surgery, so I used micropulse laser in the OR. You can see the micropulse laser tip performing the treatment. The eye looks inflamed, extremely red, and there are opacities in the vitreous chamber. So 1 hour after treatment, I decide to run some imaging and I take a picture of the fundus and I discover a surprise. Hemorrhages at the posterior pole, which are confirmed by the OCT intraretinal hemorrhage. So where are the intraretinal hemorrhage coming from? Well, my interpretation is that when I opened the paracentesis, the pressure went abruptly down, decompression reaction, and second complication, the ocular decompression retinopathy. Later, the patient underwent an Ahmed valve to restore the balance in the IOP. Now the interior segment is quiet. But he had these two complications, which were fairly new to me. It seemed an easy case. An expert surgeon should never take for granted the easy case. Anything can happen anytime. The great surgeon is the one that considers every single case as the most important one. Let's never forget this lesson.